So Christin Veasley is a co-founder and director of the Chronic Pain Research Alliance at the country's only collaborative advocacy effort that's focused on advancing a strategic research, translational, and industry effort on coexisting chronic pain disorders. She served on the National Pain Strategy and Oversight Committee, and so of course we're thrilled to have her here today to provide that overview of the National Pain Strategy. With her is going to be Dr. Sean Mackey. He is a professor, the chief of the Stanford Division of Pain Medicine, and under his leadership, it has twice been designated a center of excellence by the American Pain Society for the center's innovative approach in comprehensive, interdisciplinary, and outcomes-based care. Recently, he was co-chair of the Oversight Committee for the NIH Health and Human Services National Pain Strategy, and we are so fortunate to have these experts here to provide an overview of the day. So come on up.
Thank you so much, Mindy, and thank you, John and Cynthia and Mindy as well for including me as part of the design team and for hosting. And thanks for also inviting us to do the keynote presentation this morning. It was my privilege to serve with Sean on developing human services, brought this idea to the committee. And so for about 2 years of our lives, I think it was about 2 years, right? Year and a half, this probably took up a huge amount of space, more so for Sean since he co-chaired the initiative than I did, but I was on the committee and one of the work groups. But today we've been charged with giving you kind of an overview of the history, how we got to the National Pain Strategy, what's it all about, what was included, and to give you a little bit of update on what's happened on a federal level since the NPS was released in 2016. I'm going to give you a brief overview of kind of the early history. Sean is going to give you an overview of the IOM committee report since he was on that committee as well as the NPS. I'm going to review 3 of the 6 work groups, and then he's going to do the remainder of the 3. So this is a quote, 2 of my favorite quotes from Margaret Mead. The first says, "We are continually faced with great opportunities which are brilliantly disguised as unsolvable problems." Us in the room have been advocates as different stakeholders and part of this issue. I actually have a longtime colleague whose husband said to her, "You know, why can't you ever pick anything easy to do?" And pain has definitely been a challenge, and the community is relatively small compared to other scientific and medical areas, but we really have a dedicated group of people who have been working for decades to move this forward. And secondly, she said, "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has." So the National Pain Strategy, the genesis of it actually started not just 10 years ago, but about 20. When the National Pain Care Policy Act was being shopped around Congress. This started around 2000, 2001, for those of us who can remember back that long. And there was a set of 8 or 9 provisions in there that were discussed with Congress, and the bill floated around both sides for a while, and it never got enough support. But at the time when the Affordable Care Act came along, a few of the very key provisions from the National Pain Care Policy Act were folded into it. I'm not going to go through these in depth, but the first revolved around pain care education and training. The second focused on pain research at the NIH, and then the third was the Institute of Medicine Conference on Pain, which is now called the National Academy of Medicine. So the goal or the purposes of the IOM study were to increase the recognition of pain, to evaluate the adequacy of assessment, diagnosis, treatment, and management of pain, to identify barriers to appropriate pain care, and then establish an agenda for action. Since Sean was a member of the IOM committee, he's going to go over and give you an overview on that.
Thanks to John, to Cynthia, to Mindy for putting this together. These things take an incredible amount of work, and they've all done a great job in bringing all of us together with this, common focus on trying to change the lives of those who are suffering with pain. Also want to give a shout out to Chris Veasley, who is absolutely a force of nature. She's incredibly bright, articulate, and has a boundless degree of energy, and has devoted her life to making a real difference in this space. I've enjoyed working with her. The introduction noted that I work up the road at Stanford. I'm a physician scientist. So I've been caring for people with pain for about 20 years now, and I only do it a few days a month at this point in time. Most of the time I'm in the lab doing research or traveling. But my life mission has been, much like yours, to try to make a difference in those who are suffering. I was honored to serve on the Institute of Medicine committee that started this blueprint. So think of the IOM pain report as a blueprint, and I'm going to be careful with the languaging that I'm using. It's going to be a 30,000-foot overview of where we were, where we are, and where we need to go. The National Pain Strategy, and again I'm giving you the punchlines now, is meant to be a strategic or even tactical document. Very specific goals and deliverables. I'm going to come back to that in a moment. Let's start with the IOM, and I'm going to refer to the IOM, as Chris said, it's now the National Academy of Medicine, but I may keep falling back on the old language. The Institute of Medicine is part of the National Academy of Sciences, which was put into play by Abraham Lincoln back in the 1800s, and it is meant as our country's main overriding, nonpartisan, non-biased, non-governmental advisory group to everything related to science, education, engineering, medicine. Like many of these IOM reports, we had a specific charge because some of the criticisms, there was only a few that I got, were why didn't you take on X, Y, and Z? And the reason was because Congress told us to take on these 5 things. And you don't deviate from what they tell you to do. You have to stick to the bullet points. People ask us why we didn't take on opioids. Well, opioids aren't listed here. We did acknowledge and mention it, but that was the extent of it. When you see this slide format, these are the actual IOM slide decks. And so part of the rules with being on an IOM committee is you don't editorialize. You don't change the message. You don't change the slides. You stick to exactly what they put forward. I was a little resistant to that because I tend to be a little anti-authoritarian in my younger days. So these are the IOM slide decks. Now this is actually our slide format. And I'm going to give you a summary of what we found in the IOM pain report. Part of it was an econometric study that we commissioned out of Johns Hopkins to look at the national data. And this is where that 100 million Americans came in. It's a real number. It's been debated. It's about 35% of the U.S. adult population, which is about the same number you'll see in every developed country in the world. You'll see various estimates for it. And people will say, well, how can it be 100 million? How can it be 50 million? How can it be X million? And all of it, it depends on how you ask the questions. Just keep that in mind. As part of that econometric study, we looked at the burden of pain, and it's over $500 billion a year. It's an astounding number. That includes both direct and indirect expenses for pain. One of the key messages that we put forward is that the data we have on pain is just it's terrible, terrible quality, and we need better quality data to drive action. Some of the underlying principles we put forward in this report were the following, and I mentioned one of these in the previous slide, that it is a moral imperative, that it can be a disease in and of itself. We need to come together and provide comprehensive treatment. This idea of unimodality, single treatments, really hasn't played out well except for a few small subset of people. There's a need for a team-based approach through interdisciplinary approaches. We need to treat pain more like a public health crisis. And the beauty of that is that we can draw upon time-honored approaches and public health approaches. And that's all based on prevention. It's much better to prevent something than to try to treat it after the fact. The fact that we have a huge amount of existing knowledge. I'm continually amazed with the explosive amount of information that is being generated on a yearly basis around pain. But we're not getting it in the hands of people who care for people with pain. We're not getting it in the hands of the people who are suffering from pain. We need to do a better job. We did acknowledge the conundrum of opioids, noting that in some cases it provides tremendous gains in pain and function, and it is also, opioids have destroyed lives through addiction, diversion, overdose deaths. And that was about the extent of it in the IOM report. We noted that there is collaborative roles for patients and clinicians that could be improved upon. I'll touch base on this. And once again, I came back to the public health aspects. Okay, so diving back into the IOM slides themselves, what we have here were some recommendations, some findings and recommendations from each of the various portions of it. Some of these were in the public health aspects of it, others in prevention care, others in research, others in education. Recommendation 2.1 gets at the issue of poor quality data. Now, I'll note that there's a lot of words on these slides, and I'm just going to summarize. Let me just summarize 2.1, we need better quality data. 2.2, which I highlighted in red because that's the one that calls for the development of the National Pain Strategy. It called for then Secretary, I believe it was Sebelius, to put forward a panel to develop a strategy that would be tactical and actionable. We put forward a series of recommendations. One of these, which is gaining steam, I'm pleased to say, is the need for greater promotion enablement of self-management programs. These are typically peer-led programs that have been around for decades in the rheumatology field and the cardiovascular field. They're starting to get more headway in the pain field. They work, and they're inexpensive. We need strategies to overcome the barriers to care that I alluded to before. We need to improve the education and training of those who care for the person in pain. Again, that transcends from pre-licensure all the way to post-licensure. That means those who are in medical school, residencies, and then out into the community practices, nurses, psychologists, podiatrists, pharmacists, psychologists. I'm leaving out groups. It's not by intent. It's whoever is caring for those in pain. We need to do a better job with education and training. We need to bring the pain specialty organizations, of which there's a large number, together with primary care groups. And we need to work together to impart the knowledge that the specialty groups have with primary care to be able to have our rising tide elevate all our ships. We called for consistent and complete pain assessments, and we need to revise the reimbursement strategies that we have for pain. Too frequently, we pay for what we do to people rather than the outcomes that are generated, the quality of care that is needed. So we need to revise that. Pain education was one of the cornerstones within the Institute of Medicine report, and we said that it really has to serve as the necessary central part for that cultural transformation that Chris alluded to before. We need to expand and redesign educational programs to transform the understanding of pain. This is at the federal and the state level. We need to do this at the medical school level, which, by the way, is determined by each medical school across the country. So there's a lot of work there. We need to improve the curriculum and education, and we need to increase the number of people who are trained to care for those in pain. Closing it out on the IOM is pain research. This was a topic of great interest with the committee. And we called for the need. We called for greater effort to translate the research findings that we have into safe and effective treatment. That once again, while there's significant advances being made, there's much that still needs to be done in a mechanism standpoint. We already have a lot of knowledge out there, and we need to get that in the hands of people. We called for the NIH to designate a lead institute to take charge of this. Before this, what we had was a number of institutes who were all working collaboratively, but really without a vision, without a focus, I would say. There wasn't an institute who was taking charge and accountability. And I'm pleased to say that the Interagency Pain Research Coordinating Committee with the NIH Pain Consortium has executed this masterfully. They have designated specific institutes. In this case, I believe it's still NINDS and Walter Korschetz, who is taking the lead, and they've been funding a number of efforts and helping to guide the path forward. So props to them. We need to have better collaborations with academia and industry to develop new agents. We need to bring together private public partnerships to increase the support for interdisciplinary research. We need to be conducting more longitudinal research. One of the complaints that everybody has is that most of the studies that we have in pain only go on for 12 weeks or so, typical FDA-type trials, 12 or 13 weeks. We need studies that go out for a year or more because that's what you're living with, is long-term chronic pain. And once again, we need to increase the supportive training for those who are doing research in pain. That then leads us to the next step. So we released that document in June of 2011. Had to reach back in time. And it got a lot of attention. We were very excited about it. And then, candidly, it sat around for a while. It sat around for a while we waited for HHS to take some action on it. And I think, Chris, is this you? Or am I still rolling with this? I'll just turn to her and ask her what I should do. Recall that in recommendation 2.2, we called for the Secretary of HHS to create this comprehensive plan. That's the National Pain Strategy. And that's still me? I'm still me, okay. 2 more slides. She's got this all under control. I told you we could just finish each other's sentences here. We've got this down so well. You know, so this was meant to be that tactical plan. So remember, the IOM pain report's the blueprint. This is the down in the trenches, how do we get it done plan. And it was meant to be the first step in a long-term strategy in our country. What we did is we brought together 80 people across the country. Let me also just give you a little bit of a heads up on this. Chris mentioned that the Interagency Pain Research Coordinating Committee was the group charged with this. Then Assistant Secretary of Health Howard Koh. So I called out Howard Koh on this and I said, I think this is a terrible idea, expecting my career to be over at that point and be disinvited from any other federal work. And he just responded in an incredibly eloquent way and he said, listen, this is what we're faced with. We got Obamacare that we're trying to get out. We have sequestration that we're still dealing with, you know, in the country. We're just mired in these other priorities, and if you guys don't do it, nobody will. I thought he made a good case. So we went away, and then what happened is, shortly thereafter, I got a phone call asking me if I'd be willing to lead it with Linda Porter from the NIH. So put the naysayer in charge. What these working groups are, they're all aligned with what we put forward in the Institute of Medicine report. So these 6 working groups were not just made up, but we picked the themes in the IOM and we brought together leaders across the country to help put that forward. Chris, is it your turn?
It's my turn.
Okay.
Thank you, Sean. I remember when Sean raised his hand and said that at the IPRCC meeting. It was a very interesting meeting, and there could be many stories here about how that actually came to be, all the meetings and that took place behind closed doors in terms of trying to get the recommendations from the IOM report. There's a lot of advocacy that goes on behind the scenes to get these things moving forward. So thanks, Sean, for that overview of the IOM report and the NPS. So what I'm going to do is give just a brief overview of 3 of the work groups, and then Sean is going to do the other 3. I participated on the population research work group, and in each of these particular work groups, we were asked to give a problem statement. We were asked to give an intent statement, so what is the goal of this work group? List objectives, and they all had short, medium, and long-term deliverables, and then also measurements. And we're not going to go through all of this. It's too much for today. This is probably more than you ever want to know about the NPS. But essentially, as Sean mentioned earlier, we don't have good data. And the research for the NPS was specifically narrowed down to population research. So looking at prevalence, incidence, electronic healthcare data, that type of thing. It wasn't meant to cover all of basic translational and clinical research. It was just too big for this. There's actually another effort called the Federal Pain Research Strategy that took place right after the NPS was developed, and that is an entire basic plan for how we need to move all of pain research forward, including epidemiologic research. So the problem statement for the population research group is here. Population level data on prevalence, onset, course, impact, outcomes are not adequate to guide policies, practices to improve pain. So the intent of this group was to provide methods and metrics to guide progress towards achieving improved prevention, primary, secondary, and tertiary, and management of pain in the U.S. And the way that the NPS defined prevention, primary was the development of pain in general, right? That's right. So reducing risk. So can we get people moving more? Can we reduce their weight so that they don't have, a triggering factor or some sort of predisposition to developing chronic pain issues? Secondary was, what do we do about, how do we prevent the transition from acute to chronic pain? What can we learn about that? And tertiary was, for those people who have chronic pain, having them become more disabled. So the development of multiple pain conditions, non-pain comorbidities like psychological disorders, mood disorders, so on and so forth. So that's how we defined primary, secondary, and tertiary prevention in the NPS. So the first objective was to estimate the prevalence of chronic pain and high-impact chronic pain for defined pain conditions in various population groups. And as Sean mentioned, the IOM already had a study out. They commissioned a study to look at how prevalent is pain in the United States. Really, the intent of this group was to look at the high-impact chronic pain. So the number, as he mentioned, has been debated because people say, how can we have this many people in our country that have chronic pain and not be disabling? So within any condition, any health condition, you're going to have a range of severity. So really, the idea here was, let's take a look at looking at people who have serious restrictions associated with their pain. And there was a lot of debating that went on about this, but it was really a necessarily objective and goal. The second was to refine and employ standardized electronic healthcare data methods to determine the use and treatments and costs of care, and then also to develop a system for tracking this over time that can look at how to guide policies, how policies have changed. And happily, I'm pleased to say that this work group has actually made quite a bit of progress. So what happened after the release of the for each of the 6 developed. And I didn't list all of their names and so on and so forth, but the work is going on behind the scenes. And what initially happened is that Mike Von Korf and Ann Scheer, who co-chaired this work group, actually decided they wanted to start doing the work, even before the actual NPS was published. And one way they do this is to include questions in the National Health Interview Survey. So there was about $1 million that was put up by the National Institutes of Health to support this initiative, and questions were developed through this work group process to be included in the 2016 and 2017 NHIS survey. And the idea was we need to get a ground level population read on how many people in the United States have pain and how many of them have severe restriction and limitation associated with it, which is the high impact chronic pain. So basically, this was actually just released during Pain Awareness Month in September. It found that 20% of US adults have chronic pain, about 8% have high impact chronic pain. Both of those were more prevalent among women, older adults, previously but not currently employed, those living in poverty, those with public health insurance, those living in rural areas, and education less than bachelor's degree. Chronic pain, but not high-impact chronic pain, was more prevalent in non-Hispanic whites and in veterans. So very interesting findings. This, just want to mention that as this work has moved forward, it's kind of, this isn't actually an initiative of the NPS, but work that's gone on as a result of the interests of people within the work group. So next steps is Healthy People 2030. So this is the next decade that, of work through the Healthy People initiative that the Department of Health and Human Services will do. Our work group has now developed several questions, and the idea is instead of just having 1 or 2 questions in these surveys is to have an entire objective specifically dedicated to access of high-quality pain services. The third was to facilitate communication, and the fourth was to improve the quality and quantity of data to assess the impact of pain. And unfortunately, was a little facetious in putting this in here, but we have not made much progress in the disparities work group, and it isn't because there aren't people who don't care about it. But this work group's intent was to ensure that chronic pain is recognized as a serious public health issue and that people with pain have timely access to appropriate, safe pain management. The objectives were to develop and implement a national pain public awareness and information campaign about the impact and seriousness of pain, and to develop and implement a national education campaign around safe medication use. And again, in this area, we really have not had much progress. This really kind of falls under the purview of CDC, and it's been very difficult. And so as we talk about this today, I hope that people can think about, what research needs to take place to move forward prevention and care or disparities, what types of public education and communication strategies and campaigns might we need, because it plays an active role in moving all of the work that we're going to talk about today forward. So Sean is going to review the other 3 work groups and wrap up, and then we'll take some questions.
I similarly want to give my thanks out to Chad Helmick and the group on that population research working group. They have, I think, really helped advance our understanding of the nature of pain, and it's starting to really address this issue of that quality of data that we were referring to. We had a lot of criticism over the 100 million Americans message, because people would look to their left and look to the right and I don't see 1 in 3 people with chronic pain. And the reality is that the numbers are real, but they range from this group of people who self-manage at home, who take care of their own pain, don't see a clinician for it, to those who have catastrophic, truly disabling pain problems. And that was part of the motivation for doing that high-impact chronic pain. And I'm just wanting to drive that term home during this session and others, because I think you're going to see that term being used more and more frequently as we move forward. We had a prevention and care working group that I ended up also co-chairing this with Dan Carr at a New England Medical Center. And we brought together a group of diverse experts to pick 3 objectives. And again, Howard Koh said we want no more than 3 on each of these working groups. And what we came up with is the following. We went and we went back into the IOM Pain Report, and we're what are the major themes in the IOM Pain Report that we can take that 30,000-foot view and now bring it down to ground level and make something happen? We chose these 3. One of these is to characterize the benefits and cost of current prevention and treatment approaches. So here's the situation. We have a huge number of treatments for pain now. There's over 200 medications that can be used for pain, 200 interventional procedures, a huge number of mind-body treatments, physical and occupational therapy approaches, and self-management programs that could deliver care to large numbers of people suffering from pain at low cost. And then finally, in number 3, was to develop standardized, consistent, and comprehensive pain assessments and outcome measures across the continuum of pain. What does that mean? If you have low back pain, if you've got migraine, you come in and see a doc. If you see a dozen of them, a dozen docs, what you're going to get is a dozen different assessments of your low back pain or your migraine. And you're going to get a dozen different ways of capturing that data. Can't we do better and have some standardized approaches that we're all agreeing to and using so that we can start comparing data across groups? I'm going to move on to the services and reimbursement. Progress, by the way, on this group here, I think I left out the progress slide, or it got slipped out. There is the FDA, there's the best practices. Second here. Nope, that slide got left out. There's currently a best practices group that is taking on this issue of what are the best treatments to be using and what should we not be using in pain. That document is being released for public commentary very shortly. We encourage all of you to take a strong look at it and provide your feedback. We had one on services and reimbursement. This was all around the money. This is all about the money. And the concepts were here to try to motivate and change behaviors to incentivize multimodal, interdisciplinary care for people with pain. We wanted to enhance the evidence base for pain care and integrate it into clinical practice, and once again through defined incentives. We are all motivated by incentives. And if you're not paying a clinician anything for a particular treatment, they're not going to use it. We had a number of discussions on the call. I remember with Mark Wallace, who just works down the road at UC San Diego, who actually co-led this one with Bob Kearns out of Yale. And we were both lamenting that, for instance, at Stanford, I do team conferences multiple days a week where we bring together the clinicians where they've been evaluated by a pain physician, a physical therapist, a psychologist, nursing. We bring everybody in the room over bad Chinese food. And we talk about that person. We put together a treatment plan. And guess what? I haven't been paid for one of those in about 20 years. Not a single one. These people are just giving of their own time. Now, we have the resources to be able to do that. Most places do not, and so it doesn't get done. But that's the type of thing that we do need to incentivize that behavior. We want to tailor reimbursement to promote and incentivize high-quality, coordinated pain care. What we've learned is, once again, when you bring teams together and they're talking with each other, you get better results. And we did call out this concept of treating pain as a biopsychosocial disease. Here, in the services and reimbursement, there has been some recent publications that just came out of JAMA that are taking on some of these conditions and describing, what is the current evidence base for, in this case, low back pain? What is the prescription drug coverage? What's getting paid for from a medication standpoint for low back pain, and then also for non-pharmacologic treatments. In the professional education group, this is the last one here. This is tying back to the IOM report where education was that cornerstone, and we need to improve the education of everybody who cares for those in pain. So here, develop, review, promulgate, and regularly update core competencies for pain care education and licensure at the undergraduate and graduate levels. And once again, this is for everybody who cares for somebody in pain. And then finally, to develop a pain education portal. There has been nice progress on this, and I got to give my thanks out to Scott Fishman in particular, who is the division chief at UC Davis. What Scott has done is to help define pain education within the medical schools. He brought together a group of us. We all flew out to Philadelphia. We sat in the USMLE, which is the main boarding, the group that provides the board exams for clinicians. And we all sat there and took the tests. We got to take the medical school tests all over again and mark off which were pain questions. And what we learned for this and what Scott published is that we are asking a lot of pain questions within the medical schools, but we're not teaching the right kind of pain education in the medical schools. We're not teaching how to do coordinated, comprehensive, interdisciplinary, biopsychosocial-based care. What we instead are focusing on is how to diagnose somebody with an acute appendicitis. What is their pain, or from an acute low back pain. So props to Scott for that. And then also, send a shout out to Dave Thomas with NIDA, the National Institute of Drug Abuse, who's been really taking the lead on the Center of Excellence in Pain Education and developing a portal to put educational materials that are available for everybody. And so there's some wonderful interactive educational materials there for how to do best practices in pain care, how to assess somebody, how to appropriately care for them. And I know there's many efforts that Dave and others are doing throughout the country in this COPES program. So what happened with the National Pain Strategy? We rolled it out in March of 16. It was the same week that the CDC opioid guidelines were released. I had gotten wind of this about a month or two prior, and I was candidly livid. It takes a lot to get me livid. I'm generally a pretty chill guy, but I just thought this was an insane move. It was an insane move because I was worried the CDC opioid guidelines would suck all the oxygen out of the room when they were released. So I had just gotten done testifying on a Senate panel. I appealed to one of the senators. I called up everybody I could call up. And their belief was that if we paired these together, it would get more attention. So CDC opioid guidelines were released on a Monday. And for the remainder of that week, that was all was in the newspapers. The National Pain Strategy got released on a Friday and was buried in the media. And it was a source of frustration, but never give up, never surrender. We rolled it out. There was a federal task force appointed for implementation. Once again, my thanks to Linda Porter and her team for pulling this together. They also did, if you will, the sister or the brother to the NPS, which is the Federal Pain Research Strategy. And this was a specific effort that is analogous to the National Pain Strategy, but with a primary focus on how to improve our country's research portfolio. And they have released that. It's great reading. They did incredible work in it. It's clear that we need collaborative efforts like what's going on here, what has been brought together in this group and in others. We need to bring people together who have pain, their advocacy groups, the clinicians, professional groups, payers, and the legislators, all working together. I pulled this quote from our closing of the National Pain Strategy because I think this sums it up well. If we were to successfully implement the National Pain Strategy, Americans would recognize chronic pain as a complex disease and a threat to public health. Significant public resources would be invested in the areas of preventing pain, creating access to evidence-based and high-quality pain assessments, and treatment services, and improving self-management abilities amongst those with pain. And, most importantly, individuals who live with chronic pain would be viewed and treated with compassion and respect. So with that, let me close out. Thank you for, again, the invitation to come up and spend the morning with you and for your attention during this. And I turn it back to Cynthia, John, and Ms. Myers. And I don't know if we have time for Q&A or we're moving on.
Would anybody like to ask a question of Sean or Christin?
First of all, thank you very much. My name is Greg Holgate. I'm with Osco Wellness. And personally dealing with this issue with family and have been combating it with medical device technology. So thank you for the really good work and the great explanation and the history on this, because a lot of this I've read but didn't really get the feeling from it the way you've delivered it today. So thank you. My question is the collaboration piece. So if you just went back one slide. So if I look at the last bullet point there, I see everything but private enterprise.
Private.
God bless you.
Thank you. Great comment. Listen, here's, first of all, you're absolutely right. I'm frequently loath to make lists of people and groups because I'm invariably going to leave somebody out, not by intent, but just because of the nature, there's a large number of stuff here. So we clearly recognize the need for public-private partnerships, for industry to be involved. Industry and private enterprises often get, they're thought of kind of as a dirty word these days because they're too frequently tied to the opioid issues. And I'm going to tell you, we are not going to make major headways unless we engage those groups, because they're the ones who are going to be able to help us implement and disseminate at a very broad level.
Mention briefly that, again, a lot of this has to do with historical perspective. Shortly after the NPS was released, everything with the opioid epidemic started. And so a lot of what was done with the NPS was somewhat put on the back burner from a federal perspective. I will also make mention that since the NPS was released, I co-facilitate a task force called the Consumer Pain Advocacy Task Force, which is a group of 16 consumer patient organizations that have come together to advocate for the implementation of the National Pain Strategy. You're right that all of the stakeholders need to be included, but it takes a lot of behind-the-scenes work to even go to the place, and because when you look at it and say, well, what's been done in the last 2 years since the NPS was released on a federal level, I think we'd probably say we're a little disappointed. We wish that the implementation work groups would be a little bit more active, that there would be funding from Congress for this work. It's continuously mentioned in all of the work that's going on at HHS, but the advocacy effort needs to take place, and it needs to take place across organizations, patient advocacy, medical professional, all of, as you mentioned, enterprise, everybody needs to participate and move it forward.
Hi, Diane, thank you also for the great overview. So there's not been any new federal appropriations for implementation of the plan?
No. So there, as I mentioned, each of the 6 work groups has an implementation, a Federal Implementation Workgroup, and each co-chaired by 2 people. The agencies that have interest in participating in those objectives have participated. So the ones that Sean mentioned, and was it prevention and care? Or, no, it was for reimbursement. So there's been a task force created between NIH and CMS, and now they've started to look at what is CMS paying for. And they're going to be doing some pragmatic trials around low back pain and other common pain types to see the efficacy of these, of different treatments for chronic low back pain and for other conditions. But it by and large has been left to whichever agencies have interest and whichever ones want to dedicate some funding to the work that was outlined in the NPS.
Which is why we need to put pressure on them and make your voices heard. Sean Cavanaugh was the CMS representative on the Services and Reimbursement Working Group, and he listened to all of us complain that we weren't getting paid for those things that work. And his response is, show us the data, show us that it works, we'll pay for it. I thought it was as supportive and simple as that. So I think we need to work with those groups and show that these things that we all know do work should be paid for.